Hello, welcome to this short where we are talking serotonin syndrome, the illness that is defined by the nervous system being overstimulated by, you guessed it, serotonin. If your patient's experiencing this, you may start to see the following symptoms. There's going to be three main pillars, and these are going to be displayed via a triangle. EMS loves a good triangle. So at the top here, we have neuromuscular excitation. Specifically, I'm thinking seizures, twitching, tremors, as well as abnormally stiff muscles. Down here at the second leg, I have altered mental status. And I want you to think a little more broadly than my patient isn't a GCS of 15. They could, have an abnormally low GCS score, anything less than 15, but they could also be technically alert and oriented to answer your questions and also display the following: delirium, agitation, insomnia, and hypervigilance, when none of these things can be explained or warranted by any other means, okay? Third leg is going to be autonomic instability, thinking tachycardia, fever, diaphoresis, mydriasis or dilated pupils, and diarrhea. All of these things can come together to create some potentially deadly symptoms. Not that some of these aren't deadly enough. I mean, seizures, altered mental status, tachycardia, fever, all these things are not good for your patient and are potentially deadly. But these can lead to rhabdo, as well as metabolic acidosis and organ failure. So this is a patient that needs to be transported to the hospital as quickly as possible and safely as possible. So who is this patient? Why is this patient experiencing this, and how'd they get there? So polypharma is going to be the number one culprit for serotonin syndrome. And when I say polypharma, what I mean is the compounding effects of medications layering together that are going to produce an outcome like serotonin syndrome. So if I have multiple medications that have similar effects, they're going to compound together to create a stronger effect. And that creates that toxicity of the serotonin. So, namely, these are going to be the players that you're going to see. These are going to be SSRIs. Common ones that you may see are citalopram, fluoxetine, sertraline, SNRIs. Most common one that you might see is venlafaxine, as well as MAOIs or monoamine oxidase inhibitors. That'd be phenlazine or this is a mouthful, work with me here, isocarboxazid. And again, those are the three main types of medications that are going to work in conjunction to bring about this illness. This is that patient who began receiving psychiatric care and say they get put on an SSRI, and it takes a while to kind of dial in that dose, and maybe they start playing with the doses, and then maybe they give an adjunct like an SS or an SNRI on top of it. And they're trying to dial in that med to bring the desired effect, but as a result of that, they accidentally bring about this. So that's what I want you to think about. This is very important to obtain an accurate medical history and a med list from the patient. I know that can be very challenging at times, but I'm going to challenge you to go the extra mile and try to figure out what meds they're on, what doses they're on, and how long they've been on it. This typically starts within hours of exposure to whatever medicine triggered it, or substance, and we'll get into that in a moment. So this can be hours to a day or so, but this usually starts relatively quickly. So again, polypharma of SSRIs, SNRIs, MAOIs, that's going to be your main culprit. But something that can also potentiate serotonin syndrome or increase the chances that might happen is if someone is on any of these medications or multiple of those medications, and then illicit drugs are introduced into the picture. Now there's a whole list and slew of them, but I'm just going to go over the hits. There would be meth, cocaine, opiates, MDMA, and dextromethorphan or cough syrup, as well as maybe Vyvanse or Adderall. And again, those are brand drugs, but they can be abused and they're chemically very similar to amphetamines. So again, if someone's on these drugs up here and then they start abusing illicit drugs, that's going to compound their chances of experiencing serotonin syndrome. So, say you have that patient in front of you, what do? Okay, how am I going to treat them? All right, so first of all, we're going to think sedation, and I'm going to specifically probably go towards the benzo. So locally here, that's going to be Versed. All right, that could be for agitation, patient combativeness, scene safety, as well as seizures, okay? It could handle quite a few things that this patient might be experiencing. Active cooling, so maybe removing layers of clothes and begin cooling them if they're experiencing fever-like symptoms. Oxygen therapy, as well as airway management, as well as maybe ventilatory assistance if needed. IV, IO access, fluids, cardiac monitoring, and transport. It is imperative that this patient is seen in the emergency room. So that's what I have for you for serotonin syndrome. Someone requested this via that jot form I sent out to you guys a while ago. So hopefully this was the information that they wanted to receive. If there's something that I did not cover, please reach out to me, or if there's something that you want to see covered, reach out to me or fill out that jot form, and hopefully I can get to the content that you want and continue to bring you relevant information. I appreciate your time. Thanks.